Let's see, here we go. Hello, everybody. Today I am here with Dr. Isabelle Amigues. She is a rheumatologist in the Denver area, and we wanted to talk about osteoporosis. There's a lot of hesitation around treating osteoporosis and concerns about osteoporosis medications, but it's a very serious disease that we need to have on our horizon so we understand what's going on with it. Welcome, Dr. Amigues. I'm so excited to be able to connect with you, especially with both of us being in the Denver area. Can you tell us a little bit about yourself and your practice and
Yeah, absolutely. And thank you so much for having me. It's such a pleasure. And yes, I'm so excited. I think Denver is wonderful. Today I was like, I'm going outside. It's been a
it's
long winter.
gorgeous?
Yeah. Yeah. So I'm sorry if the light is not as perfect as normal, but yeah.
It's
So
great.
I'm Dr. Amig. I'm a double certified in internal medicine and rheumatology, and I'm actually also a doctor from France. So I did my rheumatology first in France, in Paris, and then Lyon, and then I moved to New York City, where I did another residency and then another fellowship in rheumatology again at Columbia University. So I feel very well trained. And recently, I opened the first direct care rheumatology practice in Colorado. And so I'm out of network, which allows from insurance, which allows me to see patients much longer in terms of like their appointment time and take really good care of patients. And I have to say that I am loving it, loving it. So
That's
that's
good.
me.
Good stuff. Yeah. But your patients, generally by the time they get to you, PCP's taking a crack at it, and very
Yeah.
important to have all that time. And well, my thoughts around osteoporosis is that a lot of women, don't realize how horrible the disease can be, and they really underplay it. And as a gynecologist and menopause specialist, I'll end up ordering a lot of bone densities on my patients and counseling them about osteoporosis. So thanks for joining to talk about this very important topic. But I'm just curious what your philosophy is for when to screen, and then when you might consider not treating someone who has osteoporosis versus following them. There's seems to be some hesitation in some practitioners to actually treat osteoporosis. What's your general philosophy around the
Mm-hmm.
disorder?
Yeah, so thank you for this question. It's really an important one. So I think the first thing to remember or to learn is that osteoporosis is basically imagine that the structure of your house is starting to crumble. So you're not seeing it. The house is still up, but there is, slowly the erosion, maybe, the erosion is basically causing defect into the structure of your house. And then one day there is maybe a minor event and the house falls. And maybe it's just one side of the house, and then it's another side of the house, and then it's another side of the house. And so basically what we want is to really like look at this and make sure that the foundations are good so that it never crumbles, so that we're taking good care of our foundation. And so, in terms of when to screen, I think that everyone that is menopause that goes into menopause should be screened. That is an abs. I mean, I went into menopause for my own like induced, and I had to be screened because we want to make sure that I don't develop osteoporosis, and we want to prevent it. And it's the same thing for anyone. Anyone that is going into menopause should be screened. Usually, it's around 50 years of age. So that's number one. And then there are other patients that want to be like that we want to screen is the patients who have either a fracture that looks like it could be osteoporotic, and then it's patients who have risk factor to develop osteoporosis. So patients like that has has rheumatologic condition for a long time, or patients that are on steroids, so such as prednisone. Those are patients that we will screen. And and then in terms of treatment, we have to do a little bit of digging in terms of what they have in terms of risk factor. Okay, so someone that has been on steroids, prednisone, or like steroids, inhaled steroids, even is not the same risk than someone that basically their primary care physician is doing exactly what they need. They're screening them for osteoporosis, and they're seeing just like minimal osteoporosis. It's just not the same thing. Personally, I would be in favor because in my rheumatology practice, everyone has a rheumatologic disorder. So if I screen and I find osteoporosis, I treat. There's no question. I treat. I think that there are some patients in your practice where you could just do vitamin D and calcium. But I think that is probably more and more we're realizing that this is probably where you want to just do osteopenia, like when you don't have yet osteoporosis, but you have osteopenia. And then the questions that we ask are, so if you have osteoporosis and you have a family history, like so your mom has had fractures that are osteoporotic, and I can talk about what those are, that is an indication for treatment. If you have smoked or if you smoke, that is an indication for treatment. If you drink a lot, that is an indication for treatment. If you're very small weight, like, small weight, that's an indication for treatment. I think in general, those would be my recommendation. In terms of what osteoporotic fracture is, it's fractures that happen when you would not expect them to happen. So it's basically you fall on the street, you put your hand to stop you, and you break your wrist. That's not normal. You're not supposed to break your wrist. You fall and you break your femur. It's not a high impact velocity fall. You should not break your femur. Same thing for the back. And a lot of people, and I think even in the medical community, we don't our doctors don't necessarily recognize that those are osteoporosis. You don't even need that the confirmation of a DEXA scan or bone density to say that this is osteoporosis. If you have a fracture of low velocity, that is a fracture, like that is considered osteoporosis.
Yeah, that's good. That's good to know. And I think sometimes I guess it depends on what they're doing, but a lot of times we have a lot of active patients in Denver, and sometimes it's hard
Yes.
to know what's a traumatic fall and what's not a traumatic fall, but something definitely to keep in mind. And I know in my practice recently, I've seen a number of very young women, just early menopause, 50, 51, with really significant osteoporosis. And the age of the woman, does that affect your recommendation for treatment if you have somebody that's 50 that works out, that's really healthy versus somebody that's 70 with osteoporosis? Would you still recommend the same treatment for both of those women?
Well, I think it really depends on their T-score. So if the
Mm-hmm.
T-score is just minus 2.5 and they don't want to be on medication,
Mm-hmm.
and then you may consider, okay, let's just wait 1 or 2 years and see where you're at. And if you're
Right.
starting to see a progression, then to me it's like it's a no-brainer. But it's at the end of the day, you have to have one of the issue with osteoporosis is that because you don't see it, the compliance to treatment is very low. At least with the biphosphonate, which were oral, like the first line.
Right.
And so if you don't have a buy-in by the patient, there's no point, right? Like of starting this medication. So I think that just saying, hey, take vitamin D, take calcium, make sure that you get it from your food, intakes, continue to exercise. And then let's repeat this DEXA scan in 2 years. And I wouldn't do it before 2 years because it's a standardized test. So there's no point of doing it before 2 years. So you do it at 2 years. If it's lowering, I think that's it's a no-brainer. But it's only if it's between minus 2.5, minus 2.7, like it has to be really like at the verge of being still osteopenia. And
Mm-hmm.
then remember, and then also if they have any sort of risk factor, and the big risk factor that we tend to forget is even if they are perfectly healthy, they've never been on prednisone, never needed, never had any rheumatologic disorder, but if they have a member of their family, like it's usually the mom that has had a fracture, like an osteoporosis fracture, then I think we should treat them. Again, why? Because you want to make sure that the foundation is solid.
Mm-hmm.
Um, and really, this image of the house, I think once you explain that, they're like, oh, I get this now. Of course, I want to prevent the foundation of my house to crumble, right? And
Right.
then that makes sense.
Yeah, that makes total sense. And I think they don't realize the complications from especially a hip fracture or something like that, that just huge percentage risk of having other complications.
Mm-hmm.
Is there a certain type of prevention? I see a lot of perimenopausal women and they're wondering, what can I do for my bone density? What's the best kind of exercise? How much calcium, vitamin D? Should I be on hormones? I mean, obviously that's a whole other discussion, but I'm getting a lot of requests for menopausal hormone therapy because of women having a family history. They're very concerned. They've seen their mother go through a hip fracture or other things like that. Is there kind of a prevention strategy that you would recommend for someone that's high risk?
Well, so for someone that's high risk and that has a T-score that's, like showing that there is osteoporosis, I think that they need treatment. So that is a number one.
Yeah. Saying they don't have osteoporosis, they're just trying to,
Oh,
get healthy for midlife, or maybe they have really mild osteopenia, but they want to maximize their bone mass and
absolutely.
strength.
Absolutely. So I would recommend to exercise, and it's what we call weight-bearing exercise, because the bone is actually, we are considering more and more that the bone is an organ, an endocrinologic organ. It's the same that the thyroid is, just like solid. And so every time that we are doing weight bearing, sorry, my hand, is that every time we're just making the bone stronger, right? Like, so we're creating little stress that helps our bone to restructure and like really help. So so that's like a really important one. So people who like running, that's great. I don't like running, so that's a little bit of an issue, but
Me
I
neither.
like, I like rock climbing, so I'm going to consider that it's a weight bearing exercise, not really. But walking, I like walking, so that's perfect. But those are like great. But like, it's true, like swimming, it's great. It's a great sport, but it's not what we call weight bearing. So it's not as good for osteoporosis. So maybe walk. And for the patients who are in Denver, Colorado, I mean, like, we are so lucky. Around us is just incredible. So just walk, take a walk. That's wonderful for so many reasons. Then sun. I mean, again, in Denver, Colorado, we're very lucky. There's a lot of sun, but getting outside is really good because it really helps the vitamin D to get activated, and then taking enough calcium and vitamin D. And so we can get those actually, especially the calcium, you can get it in food. So almonds has lot of vitamin
Hmm.
D. Sardines as calcium, sorry. Sardines has a ton of calcium. And actually it makes sense because you're eating the bone. So that has a ton of calcium. And so on. So there's like, there's a lot of things that can be eaten. And then if and checking the vitamin D level and seeing how that is. And if you don't have osteopenia, if your DEXA scan is normal and you don't have osteopenia, and if you have a balanced diet and your vitamin D is normal, I don't know that you necessarily want to take calcium. But I find personally that if you have risk factor, if you've seen your mom go through this, it doesn't hurt to take a little bit of vitamin and a little bit of calcium, right? So
Right.
1,000 unit or something like that. It's over the counter. It's easy. But yeah, it's like everything. You don't want to do too much either, right?
Right.
So those are like important things, and then making sure that you do your DEXA scan to make sure that it's looking good, right? Those Does that answer your question, or you want more
Yeah.
details?
No,
Yeah.
that's great. And because a lot of people ask about calcium because maybe they worry about cardiac things or deposition of calcium in the breast tissue and things like that. And so, I'm with you. I think it's better to try to get things through your diet and not overdo things. And then, as far as an adequate vitamin D level, do you usually just use like 30, kind of the standard cutoff if you were following somebody for that? Or do you recommend a higher vitamin D level?
30, what do you mean?
Oh, for the 25 vitamin hydroxy, the general vitamin D level we check on a
Oh,
blood test if we were following somebody, do you have any
okay.
certain
Yeah,
recommendation for that
e-
or
even I mean, those are like medical recommendation, but like
yeah.
I tend to actually especially because in rheumatology, vitamin D deficiency is linked to more pain, which makes
Hmm.
sense, by the way. Vitamin D deficiency is osteomalacia, rickets in kids, and that causes bone fracture that you don't see.
Hmm.
And so it causes pain. And so I tend to actually treat even at 24, between 24, 25, even lower. And I treat because it doesn't hurt
Hmm.
to get a little bit
Yeah.
of vitamin D, especially if in the winter, I know that it's going to continue to drop. And then in the summer, go outside because that's really how you get your vitamin D is going outside. It's under the skin. So go outside for a little bit, make sure that you have your hat, make sure that you're putting your skin, like your sunscreen, and still get some sun,
Yeah,
basically.
I
Yeah.
know we're
And
so
then
blessed.
we are. And then, yes, I do myself take some 1000 units of vitamin D. Again, because it gives me a sense of control and a sense that I'm doing something to make sure that I prevent osteoporosis.
Yeah. Yeah, it's so easy to get that big jug of vitamin D at Costco and try to take it as much as you can remember.
Exactly.
And then what about bisphosphonates? As a gynecologist, I don't treat complicated patients, but if they have a negative evaluation, I don't think there's anything else going on, they have mild osteoporosis, I'll definitely offer bisphosphonates. But it seems like there's so many women with reflux, or they've read about osteonecrosis of the jaw and they're worried. Can you kind of put that into your perspective? Because I feel like there's a lot of fear and around those
Right.
medications.
So I think is to um, the first thing is we have more and more medication for osteoporosis. So it's not anymore just biphosphonate. There is a lot of options now. It's the next thing, right? Like baby boomers are getting osteoporosis, so the pharmaceutical company are creating more, and that's great because now we have more options. And there's two type of option. There's like making sure that you're making bone, and there is like stopping the resorption of bone. And then you can actually do some sort of not combo but like sequential therapy. So that is number one. Number two is in terms of the osteonecrosis of the jaw, to realize that the patients who develop the osteonecrosis of the jaw are very specific. It's not the type of patient that you just described. It's not the patients who are taking care of their teeth. It's not the patients who have like perfect and pristine teeth. It's really the patients who have, a lot of them actually had like the ones that had cancer. So that,
Right.
that's like number one. And then the ones that have like work in their teeth. And so it's really not something that we see that often. It's pretty uncommon. So that's number one. Uh, the other thing that you were mentioning is the reflux. Personally, I give a lot of IV biphosphonate rather than the oral biphosphonate, just because it's a one time per year done and done, right? Like, and so I'm like, yeah, this is great. Like if you have reflux, then for sure I'm giving you, if I want to give you a biphosphonate, I'm gonna give it to you IV, intravenous, and I think it's like 30 minutes in the infusion center and you're done. And
Oh,
so that you're done for the full year. So that's great. So that is the second point. And then realizing that the treatment changes depending on your, if you have already had a fracture, if you have a lot of risk factor to have severe osteoporosis, or if you have a DEXA scan that's showing more than just mild osteoporosis, we change treatment. Now we have choice, so that it's more complicated than it used to be. Let's put it that way, because we have
yeah.
more choice. We have more choices. That's great. That's like wonderful.
Yeah, that's great. Yeah. I know I don't, really do anything with the IVs or injections or anything like that, but once a year, that's so convenient for people.
Yeah.
And then what do you generally recommend for how long you continue treatment? If you have someone with fairly mild osteoporosis and not a bunch of risk factors except maybe family history, do you like to treat them for 3 years, 5 years? Is there sort of a sweet spot that you think
Yeah.
is safer?
And yeah, so in for biphosphonate, the recommended, and then after we do what we call a holiday, but really we stop, right? And then you look and you assess, it's
Hmm.
5 years for biphosphonate, which is why, again, if you're doing the IV, it's like 5 injections and you're done. So that's pretty cool. So that's number one. But then if you're on another type of medication, you may actually need more than just, to, like, for example, Prolia, you're going to have like denosumab, you're going to have to continue that sort of indefinitely. And again, it's not a big deal, an injection every 6 months, but you have to continue, or at least follow that with another type of treatment, just because you're making bone as long as you're getting those medication, but then it decreases, and it actually decreases very fast. So you want to make bone and then keep it there with some other type of medication, like biphosphonate. So there's like some sequential therapies now. So yeah, the osteoporosis is becoming a little bit more complicated in terms of treatment, but again, that's actually in favor of us patients. I'm saying us because we all are gonna have menopause at one point or
Eventually.
another, right?
Yep.
Exactly. So it's actually in our benefit that it's more complicated because it's just more option
Right. Can get more people treated.
and better.
Yeah.
Yeah,
Yeah.
better.
And then I get asked a lot of questions about some different types of treatments, supplements. So I haven't seen a ton of data about it, but things like, should I be taking vitamin K? What about collagen? All of these supplements. I mean, any
Yeah.
real compelling data for that stuff? Or prunes? I've seen some studies talking about
Oh yeah.
prunes, but man, you got to eat a lot of prunes. I think that's going to be, 10 prunes a day. Who wants to do that? But any thoughts on some of these supplements or?
I haven't seen any compelling data. Like already the data, like to show improvement when it comes to what do you call that? Osteoporosis is so hard. Because right, like normally the best would be like to look for fractures, but then you have to do studies of like 10, 20 years. Because it might not
Right.
happen before 10 years, right? So that's too long. And so the data for prunes or supplements, I would definitely not take vitamin K. No ways. I would not.
Okay.
Because
Good to know.
it's involved in so many other things that even if it does help with your if it helps with your osteoporosis, you're causing other issues, right? Like
Right.
anti-vitamin K is anti-clotting factor. So
Right.
if I give you a vitamin K, I would be worried that I would cause clots. So that's definitely not something that I would recommend. But I think, yeah, it's just in terms of supplements, it's not really supplement. Like it's really funny to like for me because a lot of patients who want supplements don't realize that they usually don't want to take medication, but they don't realize that supplements are just a way to get those non like so we don't have to deal with the FDA, right? And you're
Right.
like, well, every time that you put something in your mouth, it is potentially hurting or helping you. And so I think that like I would much rather have my patients be cognizant of what they're eating, make sure that there is, calcium. And like, for example, almonds has a lot of calcium. And
Yeah.
so that's really where I'm at right now. It may change with the data,
Right.
but right now I'm not compelled to say that we should take vitamin K or I mean I like prunes, right? Like and there are
Yeah.
other good things about prunes. If you're constipated,
Definitely.
that's great.
Right.
But yeah, otherwise I don't know that is not my first answer. Let's put it that way.
Yeah. Yeah. No, that's great. That's really helpful. What do you think about, I have some women going on hormone therapy like after menopause or around perimenopause, hot flashes, night sweats, but then also some women who aren't so bothered by those things, but they're really worried about their bone density. Do you have any thoughts on that if they don't have any contraindications, of course, to hormone therapy?
Mm-hmm.
Because hormones, they are FDA approved to prevent osteoporosis, but I don't see a lot of us
Yeah.
generally
So
doing that. But
yeah, again, that's more like a medical advice, but I think this is really more of a this one would be more of an individual risk assessment because there's so much that goes into the decision of putting our patients on hormone replacement therapy. It used to be that we had the two choices, biphosphonate and hormone replacement therapy. That's all we
right.
had. And now we have like, I don't know, five, six. I mean, we have so many options now for osteoporosis that
Mm-hmm.
it just feels that if hormone replacement therapy is only for prevention of osteoporosis, it doesn't really. I don't know that that's my first answer. Let's put it that
Yeah.
way. I think we have other options that don't have as many potential side effects. Even I don't know.
Yeah.
That's. I think it would be really like an individual based assessment
Yeah. I
and
didn't
see.
I didn't know if you'd kind of anecdotally seen great changes in bone density in your patients, but my guess is probably by the time they come to you, they're going to be on other medications as well.
Yeah,
Avista, I
usually.
always kind of forget about Avista. I don't see that used too much anymore either. But and then are there any other rheumatologic disorders that you think should be on our radar in the perimenopause? I mean, especially as women, we just we get those more than
Absolutely.
men, but
Yeah, absolutely. So rheumatoid arthritis is a big one. It has like different moments where it likes to come. I don't know if likes to come is the right word, but
it does.
yeah, it does. And then we can, gently tell them that it needs to go away too. But yeah, basically there's two, like, so it's after delivering a baby. That's like very often I see a lot of patients that, like, it's the typical story. It's like they had a baby, they were breastfeeding, and then they stop breastfeeding, and then like they have horrible pain. And that it's rheumatoid arthritis. And then there is the perimenopause. So perimenopause, a lot of autoinflammatory syndrome, like rheumatologic inflammatory syndrome, come during menopause, perimenopause. So there's a lot of that. Rheumatoid arthritis. I don't see much lupus around that
Mhm.
time, so that's good. But yeah, rheumatoid arthritis is definitely linked. And then we can see some psoriatic arthritis. But I think if there is a patient that is suddenly developing some joint pain, that's more than just the, osteoarthritis, which is the wear and tear.
Mhm.
And I think that that's worth seeing a doc, especially it's the perimenopause, because perimenopause, you're not old, you're still considered young. And so you shouldn't have to deal with joint pain. And so then we can assess that. Sjogren is another one. So Sjogren affect the glands. So usually the first sign are dry mouth, dry eyes. That's another one that I would recommend to look at. Mhm. Yeah,
Yeah, that's helpful because sometimes I think we just think, oh, you slept funny, this hurts, that hurts, but
yeah,
yeah, really, if it's kind of out of the blue and impacting, it's always better to check it out. So,
absolutely. Absolutely.
well, this has been really helpful. I'm glad we've got to connect. And could you tell people how they can reach you or get in touch with you if they want to work with you or?
Yes, absolutely. So I'm Dr. Isabelle Amigues, and I opened Unabridged MD, which is the first direct care rheumatology practice in Colorado. You can reach us at info@unabridgedmd.com, or go to our website, www.unabridgedmd.com. Sorry, I'm like, it's always a mouthful, Unabridged MD. It meant non-edited version of me and non-edited version of my patient, so that I really see the whole of the patient and I bring myself as a whole to really take care of my patients. And so we are on social media as well, on Instagram and TikTok, I think, and Facebook. And I just put it out there. Whichever platform you prefer, I should probably be on it at Unabridged MD. And we talk about osteoporosis, and I have my podcast also on Unabridged MD, where we talk about all health related things. So yeah,
Very,
and then I'm in Denver, Colorado, like you.
yeah, very good. And I'll
Yeah.
I'll post all your information in the podcast as well, so people can reach out to you. And I love to see your posts on. I'm learning about osteoporosis, things I didn't know, and rheumatoid arthritis, and it's very helpful because I have so many patients with those conditions. So important. So, all
Yeah.
right. Well, thanks again.
Thank you so, so
All
much. Such a
right.
pleasure.
Take
Thank
take
you.
care. Bye.